So we are on endocrine bone disorders, and now we'll be going through the most important regulator of calcium, that is the parathormone pathology, which is most commonly called as hyperparathyroidism. As we know that our thyroid gland, just there are four parathyroid glands beyond our thyroid gland, and they secrete a hormone which is called as parathormone. In this, we'll be going through its pathology, clinical features, diagnosis, and treatment. So this is diagram is showing a thyroid gland of the body. This is the left lobe, the right lobe, and this is the isthmus. This is how there are four glands usually present, two superior and two inferior. Usually at least two glands should be present for normal functioning of the body, but in case if they get enlarged, in case of primary hyperparathyroidism, they need to be resected. This is actually diagnosed. Hyperparathyroidism means excessive parathormone levels, that excessive PTH levels. It could be primary, secondary, or tertiary. Primary cause is actually something inside the parathyroid glands which is secreting parathormone, which could be parathyroid adenoma or hyperplasia. Secondary is that normally the parathormone is normal, parathyroid glands are normal, but they have to be secrete excess of PTH because of low calcium levels. Now, why this low calcium level would be there? This could be multiple causes. Either the calcium is not absorbed from the gut due to vitamin D deficiency, or something is wrong with the gut. For example, there's ulcerative colitis, sprue, or there may be Crohn's disease. There's just not enough calcium is being absorbed from the gut. Therefore, like parathyroid glands has to hyperfunction or function more than normal, so that they have to increase more parathormone, PTH, so that the increased calcium absorption can take place. But now the problem is to restore this calcium, they will not get calcium from the gut, which was already defective. Rather, they will get calcium from the bones and throw it into the serum, so that the calcium metabolism is restored. Or it could be secondary due to kidney problems. If the kidney is just not absorbing enough calcium, there is maybe a renal failure, a chronic kidney disease, and certain things like that. It's just not absorbing enough calcium, so overall hypocalcemia occurs. Although this would concomitantly release increased absorption of calcium in the gut as well, but this may not be high enough to replace or restore the calcium metabolism. So now again the parathormone glands would secrete more PTH. This would in turn restore the calcium and levels in the serum or ionic levels in the body, but at the cost of bones, that it will take the calcium from the bone via bone resorption and restore the calcium metabolism. This results in persistent hypocalcemia. A tertiary, what actually happens once the secondary cause has been removed. For example, the patient was having hyperparathyroidism due to, for example, non-functioning kidney. He or she had undergone a transplant, and now she can have a normal kidney function. But despite now the secondary cause has been removed, which was actually causing parathyroid glands to function abnormally, then still the hyperplasia which has already occurred will cause the parathyroid glands to secrete PTH levels which are above the baseline. This will result in a tertiary kind of a hyperparathyroidism. Eventually, it causes autonomous overactivity due to secondary hyperplasia. Now, what happens? Once the PTH is released in the blood, it causes enhancement of calcium conservation. This is increased glomerular filtration of calcium, leading to increased absorption. Although absorption from the kidney is increased, but this may still result in hypercalciuria. That still a lot of calcium may be lost into the urine by the kidneys, because the kidneys may be not good enough or may be defective. Increase in the urinary phosphate due to suppressed tubular resorption. Changes are seen in the kidney include calcinosis, stone formation, recurrent infection, and impaired function. Calcification of soft tissue, because all this hypercalcemia somewhere has to be laid down. If it's not laid down in the bone, then the calcium is laid down in the soft tissue. General loss of bone substance, because the parathormone or PTH actually activates osteoclast. Osteoclast causes a bone resorption, therefore weakening the bones. Osteoclastic hyperactivity produces subperiosteal erosions, endosteal cavitation, and osteitis fibrosa cystica. The hemorrhage and giant cell reaction within the fibrous stroma. Usually, calcium, if it is laid down in the soft tissue, this may result in giant cell reaction and hemorrhage. So, this is usually primary hyperparathyroidism, that is, the defect was primarily in the parathyroid glands, which is usually caused by a parathyroid adenoma. As you can appreciate, there are two superior and two inferior parathyroid glands which are present just behind the thyroid in a normal adult. This could be only one could be defected, resulting in an enlarged parathyroid gland due to parathyroid adenoma. So this would result in excessive PTH secretion and would result causing primary hyperparathyroidism. Usually it is seen as middle age, 40 to 65 years and more affected. Women are affected twice as more as men. Diagnosed by a biochemistry test revealing increased serum calcium level, low phosphate levels, and high PTH levels. And if the scintigraphy is done for the parathyroid gland, this would show the hyperactivity leading to parathyroid adenoma. Other features, whether it is primary, it's secondary, or it's tertiary, the most common features are actually of hypercalcemia. As I just told you, that it's moans, psychic moans, abdominal groans, bones and stones, broken bones and stones. This is what you need to remember. There are abdominal symptoms, there are kidney symptoms, there are psychological symptoms, and then the problem is the bones as well. The bones have become weak, and so weak sometimes that they may result in a fracture. Classical symptoms include anorexia and nausea, abdominal pain, depression, fatigue and muscle weakness, polyuria, kidney stones, which is also called as nephrocalcinosis, joint symptoms such as stiffness, pain, and eventually may lead to chondrocalcinosis, and osteoporosis, that are actually due to osteoclastic activity. There is actually bones have become weak due to resorption of the bone from the resorption of the bone to release calcium into the blood. Now, what would certain X-rays present? Now, if you see, this is an X-ray of a lumbar spine. If you can appreciate, this may sclerosis over here, but look at the density of the vertebra. They look so much osteoporotic. And if you see this vertebra, it is showing a collapsed fracture. The bones have actually become so weak that they just collapse. Now this is showing humerus, and if you can appreciate over here, this is kind of cavitatory kind of a lesion which is in the proximal third of the humor. Sometimes the hyperparathyroid, there's a specific term for this called as brown tumors. Why they are called brown tumors? Because they sometimes present as tumor-like lesions, a lytic lesion in the bone which is actually eating up the bone from inside out. And eventually once the calcium levels are raised, PTH levels are highly raised, and then there's low phosphate levels. These kind of tumors are actually, they're not true tumors, but they are pseudo kind of tumors, which is due to hyperparathyroidism hormones. Osteoporosis, including vertebral collapse and areas of cortical erosions, are seen. Hyperparathyroid brown tumors should be considered in differential diagnosis of atypical cyst-like lesions of the long bone, especially if a child comes with the ABC or UBC, that is aneurysmal bone cyst, the unicameral bone cyst of the proximal humerus. In any case of a lytic lesion, we should keep that hyperparathyroid brown tumors in mind. Classical feature is subperiosteal cortical resorption of the middle phalanges. If you see it over here, these are the middle phalanges, subperiosteal resorption is going on. And non-specific features include renal calculi, which is called as nephrocalcinosis, and chondrocalcinosis, that increase calcium deposition in the joints. So how to make the diagnosis? We'll get profile of the calcium, phosphate levels, and PTH levels. There will be hypercalcemia, hypophosphatemia, and raised serum PTH concentrations. Once we know that, we have formed a preliminary diagnosis of hyperparathyroidism. The next thing comes is whether it's primary. whether it's secondary or it's tertiary. Now that will be ruled out depending upon the history, examination of the patient, and what else. We need to do some kind of a scintigraphy as well, so that we can assess the activity of parathyroid hormone. If it's primary hyperparathyroidism, this will result, this hyperactivity of PTH gland would result in, we would know that most likely it's parathyroid adenoma. If this hyperactivity is there, but maybe due to if this patient has a deranged RFTs, this means most likely this patient has secondary hyperparathyroidism because the kidneys are not functioning properly. Serum alkaline phosphatase is raised usually in case of osteoarthritis fibrosa as well. So exclude other causes of hypercalcemia in which PTH levels may be reduced. We need to rule out certain hyperthyroid causes as well. For example, hyperparathyroidism comes into differential diagnosis in all types of osteoporosis and osteomalacia. So we should know that detailed history and examination would tell us whether it is first hyperparathyroidism or not, and then whether it's primary, it's secondary, tertiary. That would define that would actually dictate the treatment. For example, if we know that it is secondary hyperparathyroidism due to chronic renal failure, so we need to treat the renal failure. We don't need to treat the hypercalcemia and hyperparathyroid hormone levels. So what is the treatment? For example, if it is diagnosed with primary hyperparathyroidism, which was due to parathyroid adenoma, then the treatment is parathyroidectomy. You need to take that out. Then other treatments, but if it was secondary, we need to treat the renal failure. If it was due to decreased absorption of calcium from the gut, we need to treat Crohn's disease and ulcerative colitis like that. And if it was tertiary, for example, it was just due to hyperplasia, then probably a parathyroidectomy may also be indicated. Certain indications for parathyroidectomy include hypercalcemia, renal calculi, nephrocalcinosis, and severe osteoporosis may be present. Coming to the treatment of hyperparathyroidism, the initial treatment is actually, as they have high calcium, and hypercalcemia usually makes them lose lot of fluids through diuresis. So these patients are really dry. So keep them hydrated. If they come in acute, give them IV fluids, and normally ask them to drink plenty of water. Decrease calcium intake, that is if there is no acute episodes of hypercalcemia. And other is post-operative hypercalcemia. But if it is an acute treatment, then you need to give them IV fluids first, give them steroids, give them IV bisphosphonates. There is a term called as post-operative hypercalcemia due to Hungry bone syndrome. So what happens is, for example, a patient had a parathyroid adenoma. He had for some times he had hyperfunctioning of parathyroid gland. It was producing more PTH. This was leading to hypercalcemia, and the PTH was activating osteoclast so that there was increased bone resorption. So what happened is, once that adenoma was removed, the bones are actually hungry. So what happens is that this all calcium is actually absorbed, leading to some kind of hypocalcemia transiently. So this is called as hungry bone syndrome. So increased vitamin D has to be supplemented, so that vitamin D causes increased absorption from the gut, so that the blood calcium levels are actually maintained. In this section, I have gone through the function hyperparathyroidism. We have just told you that this primary, secondary, or tertiary. In primary hyperparathyroidism, problem is with the parathyroid gland itself, for example, in case of parathyroid adenoma. In secondary, there's some other organs such as chronic renal failure, or there may be a decreased absorption calcium in the gut, which is actually secondarily causing the hyperfunctioning of parathyroid gland. In case of tertiary, once the offending agent which was causing the secondary parathyroidism was already removed, but despite that, parathyroid gland now has hyperplasia, and due to hyperplasia, it's secreting PTH levels above the normal limits, therefore creating a kind of tertiary hyperparathyroidism. The treatment for primary and tertiary is parathyroidectomy, but in secondary hyperparathyroidism, we need to rule out the cause, what is causing it, and then treat it accordingly. Thank you very much. Keep watching sqadia.com.